Hello everybody and welcome to Chapter 3, Week 4 of phlebotomy class. Today we'll be talking about communication and patient diversity. And so it's important for us to understand a few of the following terms. For instance, communication is a process of exchanging information with others. It's a process of sending and receiving messages. People communicate by using signs and symbols such as words, drawings, pictures, and emojis. They also communicate through their behavior. The simplest form of communication is a three-step process that takes place between two people. In the first step, the sender, the person who communicates first, sends a message. In the second step, the receiver receives the message. The receiver and sender constantly switch roles as they communicate. The third step involves providing feedback. The receiver repeats the message and responds to it in some way. This lets the sender know that the message was received and understood. Feedback is especially important when working in a healthcare setting. Phlebotomists must take time to make sure patients understand their messages. Effective communication is a critical part of any healthcare worker's job. Phlebotomy technicians must communicate with their supervisors, their care team, patients, and family members. A patient's health is affected by the quality of communication among the healthcare workers who care for them. Phlebotomy technicians may also need to communicate clearly and respectfully in stressful or confusing situations. Now, communication can be either verbal or nonverbal. Verbal communication is pretty simple to understand. It involves the use of words spoken or written. When communicating verbally, it's important to use words that have the same meaning to both the sender and the receiver. So speaking in very elaborate medical terms may not be appropriate. Misunderstanding may occur if each person interprets the same words differently. For example, if a phlebotomist asks of a patient if his veins roll, the person might not understand what that question actually means. Nonverbal communication is communicating without using words. An example of nonverbal communication is a person extending his arm and rolling up his sleeve. This communicates that the patient is ready to have his blood drawn, although it's still important to explain the procedure and confirm consent before touching the patient. Nonverbal communication also includes how a person says something. For example, a phlebotomist may cheerfully say, "I'll be right with you, Mr. Gonzalez." This communicates that the technician is ready and willing to work with the patient, but is delayed at the moment. Saying the same phrase in a different tone or emphasizing different words can communicate frustration, annoyance. "I'll be right with you, Mr. Gonzalez." See that difference in context there? Body language is another form of nonverbal communication. Movements, facial expressions, and posture can express different attitudes or emotions. Just as with speaking, body language sends messages. Other people receive and interpret them. For example, slouching in a chair and sitting erect send two different messages. Slouching says a person is bored, tired, or indifferent. Sitting up straight says that the person is interested and respectful. Other examples of positive nonverbal communication include smiling, nodding one's head, and making eye contact with the person who's speaking. Sometimes people send one message verbally and a very different message nonverbally. Nonverbal communication often illustrates how someone is feeling. This message may be quite different than what he's saying. For example, a patient who says, "I'm not nervous at all," but is clenching the armrest of the chair and biting his lip is sending a very different message. Paying attention to nonverbal communications help phlebotomists give better care. In this example, the technician should be aware that the patient is likely experiencing anxiety about the procedure despite what they say. So again, this process of communication consists of sending a message, receiving a message, and providing feedback. So sometimes even the most well-intentioned examples of communication can be disrupted or blocked. We call these barriers to communication. And it's important to understand these communication barriers and maybe how to overcome them. For example, if the patient does not hear the phlebotomist, does not hear correctly, or does not understand, the phlebotomist should stand directly facing the patient. He or she should slowly and clearly speak to the patient. He should not shout, whisper, or mumble. The phlebotomist should speak in a low voice using a pleasant tone. Learning Objective 5 includes information on communicating with a patient who has a hearing impairment. Maybe your patient is difficult to understand. The phlebotomist should ask the patient to take time to listen. You can ask the patient to repeat or explain the message and then state the message in their own words to make sure that they've been understood. It's possible the phlebotomist or the patient or others use words that are not understood. The phlebotomist should not use medical terminology with patients. He or she should speak in simple, everyday words and ask what a word means if he is not sure. If the phlebotomist uses slang or profanity, well, the phlebotomist should never use these unprofessional words and expressions. They may not be understood, and they may lead to hostility on the part of the patient. Phlebotomists should avoid using cliches. Cliches are phrases that are overused over and over again and really don't have any meaning for anything. For example, everything will be fine is a cliche. Instead of using a cliche, the phlebotomist should listen to what the patient is really saying and respond with a meaningful message. A patient who's having their blood drawn to see if they're having a heart attack, who's actively having chest pain, is not going to believe everything is going to be okay. And it's usually inappropriate for the phlebotomist to say that, even though it may be well-intentioned. Instead, you can say something like, "I understand that this may be scary. What can I do to make you feel more at ease?" The phlebotomist should never respond with the word "why." Phlebotomists should avoid asking why when a patient makes a statement. Why questions make people feel defensive. For example, a patient may say he or she has changed their mind and does not want a blood drawn. The phlebotomist asks, "Why not?" He may receive an angry response. Instead, he or she can ask, "Do you have any questions about the procedure that he can answer?" The patient may be willing to discuss the issue. Specific questions about the reasons for the test should be referred to the healthcare professional who ordered it, and any other questions that the phlebotomist cannot answer. Phlebotomist asks questions that only require a yes-no answer. The phlebotomist should ask open-ended questions that need more than a yes or no answer. Yes or no answers end conversations. They limit the amount of information that can be spread. For example, instead of asking the patient, "Are you nervous about this?" the phlebotomist can say, "How have blood draws gone for you in the past?" The phlebotomist should not offer his or her opinion or ever give medical advice. Giving a medical advice is not within the phlebotomist's scope of practice. It can be dangerous, causing both ethical and legal difficulties. What happens when you have a patient who speaks in a different language? If a patient speaks a different language than the phlebotomist does, the phlebotomist should speak slowly and clearly. He or she should keep their messages short and simple. Should be alert for words the patient understands and also be alert for signs that the patient is only pretending to understand. If the patient does not understand, or the patient prefers to communicate in their own native language, a professional interpreter or interpretation service should be used. Communication boards with pictures can also be helpful in these situations. Phlebotomists should follow facility policies when dealing with language barriers. No matter how a patient behaves and communicates, it's always the responsibility of the phlebotomist or any medical professional to follow these steps to ensure accurate communication. 1. Be a good listener. The phlebotomist should allow the other person to express her ideas completely. You should concentrate on what the patient is saying and not interrupt. The phlebotomist should not finish the patient's sentences even if he or she knows what she's going to say. When the patient is finished, the phlebotomist should restate the message in their own words to make sure that the patient's been understood. Provide feedback. Active listening means focusing on the person sending the message and giving feedback. Feedback might be acknowledged, a question, or repeating the sender's message. The phlebotomist should offer general but leading responses such as "oh," or "go on," or By doing this, he or she is actively listening, providing feedback, and encouraging the sender to expand on the message. Bring up topics of concern. If the phlebotomist knows that a topic that might concern a patient, He or she can raise the issue in a general, non-threatening way. This lets the patient decide whether to discuss it. For example, if the phlebotomist observes that a patient is fidgeting or acting nervous, he could say, "Mrs. Jones, you seem a little unsure about this." Understand the importance of touch. Softly patting an anxious patient's hand or shoulder, or holding their hand, may communicate caring. It may be reassuring. Some people's backgrounds may make them less comfortable with being touched, so it's a very subjective term here. The phlebotomist should ask permission before touching. A patient should be sensitive to his or her feelings. Phlebotomists must touch patients in order to do their jobs. However, they should recognize that some patients feel more comfortable when there is a little physical contact as possible. The phlebotomist should adjust care to each patient's needs whenever possible. Ask for more. When a patient reports concerns or anxiety, the phlebotomist should have him or her repeat what he has said and ask him for more information. Anything the patient reports should be documented word for word. Never ignore a patient's concerns. Ignoring concerns can be considered negligent behavior. The phlebotomy technician should work to understand the patient's concerns and addresses, even if they are within her scope of practice. Patient concerns should always be reported to the nurse if the phlebotomist is unable to address them, or if they are beyond the phlebotomist's scope of practice. Never talk down to a patient. The phlebotomist should talk to patients as they would to any person that they are familiar with, such as family or friends. Well, maybe not so much friends. It's also important not to talk down or act as if the patient cannot be trusted to understand. Guidelines for communicating with patients whose situations might require a special approach are found in Learning Objectives 5. And finally, be empathetic. Now, empathetic is a little different than sympathetic. The phlebotomist should try to understand and identify with what the patient is going through. This is called empathy. He or she can imagine how it might feel to have a strong fear of needles or blood, or to be experiencing symptoms that might indicate serious illness. The phlebotomist should not tell the patient she knows how he feels, because he or she does not know exactly how a patient feels. She can say things like, "I know this may be difficult, I'll make it as easy as possible," and so on. So although a full course in medical terminology is beyond the scope of what we're trying to accomplish here, it's still important for the phlebotomist to have a familiarity with some common medical terms and abbreviations that we'll cover, such as syncope, which is another word for fainting, loss of consciousness, something that the phlebotomist may have to be concerned about when patients have an overt fear of blood. When a patient has skin that is blue or gray, it is called cyanotic or cyanosis. Medical terms are often made up of roots, prefixes, and suffixes. A root is a part of the word that contains the basic meaning of the definition. The prefix is the word that precedes the root to help form a new word, and the suffix is the word part added at the end of the root that helps form the new word. Prefixes and suffixes are called affixes because they are attached or affixed to a root. Here are some examples. The root phleb, F-L-E-B, or phlebo, means vein. The suffix itis means inflammation, so phlebitis is inflammation of the vein. The prefix anti means against. The root coagulant means to clot, so an anticoagulant is a substance that stops blood from clotting. It's very important for the phlebotomist to know if their patient is on any type of anticoagulant medications, which can make it more difficult for them to control bleeding after the procedure. The root hemo means blood. The suffix stasis means slowing or stopping. So there in part, hemostasis is the act of stopping the flow of blood. The body has its own intrinsic way of stopping blood, but sometimes this may have to be assisted by the phlebotomist. When speaking with patients, phlebotomists should use simple, non-medical terms. Medical terms should not be used because they may not be understood, but when speaking with the care team, using medical terminology will help give more complete and accurate information. Abbreviations are another way to communicate more efficiently with care team members. For example, the abbreviation CBC means complete blood count, a common blood test. HGB means hemoglobin, which is the oxygen-carrying protein in red blood cells. The word stat, which is a shortened version of the Latin word statim, means right away. A patient who has been ordered to not consume any food or liquids would be listed as NPO, nothing per os, or Latin for nothing by mouth. Phlebotomy technicians should learn their facility's standard medical abbreviations. They can use them to report information briefly and accurately. They also must need to know these abbreviations to read requisitions, testing, or orders. Important medical terms, abbreviations, and symbols will be introduced throughout this book. And a comprehensive list is also included in the instructor's guide. There may be other terms they use in the facility as well, so it's important for the phlebotomist to be familiar with common terms. It is also very important to remember the rules of abbreviation and never make up your own abbreviations. There are certain standard medically approved abbreviations, like we mentioned CBC, but there are some that can be misinterpreted. For example, the abbreviation WNL might be perceived as within normal limits, but a lawyer might see it as we never looked. So that's not an approved abbreviation. So be careful with how you document things. Just on a quick note, it's probably less important to abbreviate documentation these days because most documentation, which we'll talk about in a minute, is done electronically on computers, which give you almost an unlimited amount of space to write what you need to do, as opposed to your old-fashioned paper requisitions that gave you a very limited amount of space. So if given the choice, it's always probably better to write out the full word than abbreviate to avoid any type of misinterpretation. And just to remember, medical terms and abbreviations make communication between healthcare workers more accurate and efficient, but they may also confuse patients. So use everyday language with patients. In the next segment, we're going to talk about the importance of accurate documentation and recording of events during a patient interaction. And just to briefly describe some terms, the term documentation in healthcare is the creation of a record of care given to a patient. An incident is an accident, problem, or unexpected event during the course of care which is not part of the normal routine in a healthcare facility, such as an accidental needle stick or mislabeling of a specimen. Objective refers to what a person sees, hears, touches, or smells. Okay, as opposed to subjective, which is what a patient complains of in their own words, which cannot be objectively assessed. Depending on the facility, documentation might be done using computers or tablets, in other words electronically, or on paper, manually, which is less and less common. There are very strong legal aspects to careful documentation that are important to remember. For one, it's the only way to guarantee clear and complete communication among all the members of the healthcare team, from the physicians to the nurses to the technologists to the other specialists and so on. Documentation is a legal record of every part of a patient's treatment. Medical charts can be used as legal evidence. And one famous lawyer, whose name I cannot recall, basically said that if it's not documented, it was never done. So documentation helps protect healthcare workers and their employers from liability, providing what they did when caring for patients. If it wasn't documented, it wasn't done. Documentation also gives an up-to-date record of the status and care of each patient, which is important to see how that patient is trending, whether for better or for worse or for nil. So the following are some very important take-home points and guidelines for careful documentation. For one thing, document procedures immediately after they're performed. This makes details easier to remember and recall. Always wait to document until after a procedure has been completed. Do not record any care before it's been done. Collection tubes should not be labeled and initialed until a blood draw has been successfully completed and the patient is confirmed that the label is accurate. Use blue or black ink when documenting by hand. Write as neatly as you can. Blue or black ink are the only colors that are legally acceptable on handwritten documents. If you make a mistake, draw one line through it and write the correct information. Write your initials and the date. Do not erase what you've written. Never use correction fluid. This can give the impression that something is trying to be covered up. Documentation done on computer is time-stamped. It can be changed only by entering another notation. Sign your full name and title, for example, Sarah Martinez, phlebotomist, and write the correct date and time. Document as specified by your facility. Ensure the patient identification, specimen labels, and requisitions match. Documentation may need to be done using a 24-hour clock or military time. Regular time uses the numbers 1 to 12 and shows each of the 24 hours in a day. In military time, the hours are numbered from 00 to 23. You'll see more on this in a moment. And just remember that at some facilities, computers or tablets are used to document patients' care. A computer may remain in a patient's room for care team members to input information each time they provide care. A computer may be in the hallway for staff members to use. A computer or tablet may also be carried from room to room for documentation. Computers record and store information that can be retrieved when it is needed. This is faster and more accurate than writing information by hand. If your facility uses computers for documentation, which most do, you'll be trained to use them, and you'll be trained in the HIPAA privacy guidelines to apply to computer use. Make sure nobody can see private and protected health information on your computer screen. Confidential information should not be shared with anyone except the care team. You want to make sure you take all steps to protect patient privacy and secure patients' personal health information. So this diagram is a comparison between regular standard time that most of us are used to and 24-hour clock or military time, which is commonly used in medicine. So if you look in the middle ring, you see how time is expressed ordinarily. Midnight is 12 o'clock, 1 a.m. is 1 o'clock, 3 a.m. is 3 o'clock, 7 a.m. is 7 o'clock, and then you go around until the afternoon where it starts all over again. So 1 o'clock in the afternoon would be 1 o'clock p.m. 2 o'clock would be 2 o'clock p.m. In military time or 24-hour clock time, we want to be a little more specific than that. So at midnight, if you look in the inner circle under the AM, midnight is either expressed as 4 zeros or 2400. Then it gets a little more specific from there. So 1 o'clock AM is expressed as 0100 hours. There's no AM or PM. 4 o'clock is 0400 hours. 10 o'clock is 1000 hours. Now when you get to midday afternoon, what we would commonly call 12 o'clock PM, 24-hour clock would refer to it as 1200 hours. So that's 12 o'clock cannot be misinterpreted as midnight or midday. 1 o'clock would be expressed as 1300 hours. So you would just add 100 to the initial 1200 hours. 2 o'clock would be 1400. 3 o'clock would be 1500. You're basically adding to each of those 1200 counts. Remember these rules for converting regular time to military time. To change the regular hours between 1 o'clock p.m. to 11:59 p.m. to military time, add 12 to the regular time. The minutes and seconds never change. And as again, midnight may be written as 000 hours or 2400 hours, depending on your facility's policy. Incident reports are also essential documents for phlebotomists to understand. An incident is an accident, problem, or unexpected event during the course of care. It's something that's not part of a normal routine. An accidental needle stick or patient losing consciousness and hitting their head is an incident. Other issues that must be reported include problems with specimens, containers, patient identification, or incorrect orders. We'll discuss more about incidents in chapters 9 and 10, but state and federal guidelines require that incidents be reported in an incident report. An incident report may also be called an occurrence or an accident or an incident or event report. Either way, it's a report that documents the incident and the response to it. The report is factual, objective account of what happened. Objective information is based on what a person sees, hears, touches, or smells. It's collected by using the senses. It does not include opinions or assumptions about the causes. If a patient falls, for instance, and the phlebotomist did not see it, he should not write, "Mr. Smith passed out and fell." Instead, he should write, "Found Mr. Smith unconscious on the floor." Or, "Mr. Smith states that he passed out and fell." The phlebotomy technician should write brief and accurate descriptions of the event as they happen without placing blame or liability within the report. The information in an incident report is confidential and intended for internal use and help prevent further incidents. Incident reports should be filed when any of the following occurs: a patient falls, a healthcare worker makes a mistake in care, including collecting an incorrect specimen or collecting a specimen from the wrong patient or the wrong site, a patient or coworker makes sexual advances or remarks, anything happens that makes a healthcare worker feel uncomfortable, threatened, or unsafe, a healthcare worker gets injured on the job, healthcare worker is exposed to blood or body fluids, healthcare worker patient receives an accidental needle stick, a patient is injured in some way during the course of a blood draw. So reporting and documenting incidents is done to protect everyone involved. This includes the patient, the employer, and the phlebotomist. When documenting incidents, a phlebotomist should complete and report as soon as possible and give it to the supervisor. This ensures that details are not forgotten. So when documenting an incident, it's important to follow the steps. Tell what happened, state the time, and the mental and physical condition of the person. Describe the person's reaction to the incident. State the facts, do not give opinions, just as we said before. Do not write anything from the incident report on the patient's medical record. That is a separate type of documentation. Describe the actions taken to give care, and describe and document that you had notified the appropriate supervisor. We want to try to protect our patients and ourselves from something called a sentinel event. A sentinel event is an unexpected occurrence that results in a serious physical or psychological injury or even death. A sentinel is a soldier who stands guard. Sentinel events are called sentinel because they signal the need for an immediate investigation and response. An example of this type of event is a blood transfusion error that results in a patient's death. Sentinel event must be reported to the proper agency. So for the next segment, we want to be familiar with the following terms. The term impairment means a loss of some type of function or ability. Hearing impairment means loss of hearing. Cognitive impairment means loss of ability to think clearly. Populations. In healthcare, a particular and distinct group of patients. It could be the elderly, it could be the impoverished, it could be the homeless. It depends on what you're talking about. Pediatrics is a branch of medicine dealing with people under the age of 18. Although a lot of healthcare facilities that are pediatric based will see patients up to 21, sometimes even 26, depending on insurance guidelines. The term geriatrics is a branch of medicine dealing with an elderly patients, and as country's population is growing older and older, and the older population is growing larger and larger, this is an expanding need for healthcare services in geriatrics. And a developmental disability is a disability that is present at birth or emerges during childhood or early adulthood that restricts physical and/or mental ability. So phlebotomists have the ability to work with many different people of different backgrounds and have to develop some means of adjusting and preparing to communicate effectively with all patients. So let's go over some guidelines of how to communicate with some patients who might have difficulty communicating under normal circumstances. For example, hearing impairment. There are many different kinds of hearing loss. A person may be born with hearing impairment or it may happen gradually. Deafness is a partial or complete loss of hearing. It can occur as the result of heredity, disease, or injury. In the elderly, aging commonly causes loss of hearing. People who have hearing impairment may use a hearing aid, may read lips, or even sign language. People with impaired hearing also closely observe the facial expression and body language of others to add to their knowledge of what's being said. So, as far as guidelines go, if the person has a hearing aid, make sure that it is turned on and working properly. Reduce or remove background noise, such as televisions, musics, and loud speech. Get the patient's attention before speaking. Do not startle the patient by approaching from behind. That's if you know. Walk in front of her or touch her slightly on the arm to let her know you're near. Speak clearly, slowly, and in good lighting. Directly face the person. Ask if he or she can hear what you're saying. Do not shout or mouth words in an exaggerated way. It does not work. Keep the pitch of your voice low. Patients may read lips, so keep your hands away from your face while talking. If the patient hears better out of one ear, try to speak and stand to that side. Use short sentences and simple words. Avoid sudden topic changes. Repeat what you have said using different words when needed. Some people who are hearing impaired want you to repeat exactly what was said because they missed only a few words. Use picture cards or a notepad as needed. Some patients who are hearing impaired have speech problems and may be difficult to understand themselves. Do not pretend you understand if you do not. Ask the patient to repeat what was said. Observe the lips, facial expressions, and body language. And tell the patient what you think you heard. You can also request the patient write down the words. Vision impairment can affect people of all ages. Some vision impairment causes people to wear corrective lenses such as contacts or eyeglasses. So, in general, when working with the visually impaired, identify yourself immediately when you approach the patient. Do not touch the patient until you have said your name. Explain why you're there and what procedure you will perform. You should be doing that anyway. Let the patient know if you need to step away at any time and when you have completed the blood draw. Do not just simply walk away. Make sure there's proper lighting in the room. Face the patient when speaking. Always tell the patient what you are doing as you are performing procedures. Give specific directions such as on your right or in front of you. Talk directly to the patient whom you are assisting. Do not talk to other patients or staff members at the same time. Cognitive impairment affects a person's ability to think logically and clearly. A certain amount of cognitive impairment is a normal change of aging, and illnesses such as Alzheimer's disease can cause a more dramatic form of cognitive impairment. Patients with advanced form of cognitive impairment are likely to have family members or other caregivers assisting them as they receive medical care. But these communication guidelines are still important to remember. Always approach from the front, never startle the patient, smile and look happy to see the patient, be friendly. Try to minimize background noise and distraction. Always identify yourself and use the patient's name. Continue to use the patient's name as you provide care. Speak slowly using a lower tone of voice than normal. This is calming and easier to understand. Repeat yourself, using the same words and phrases as often as needed. Use signs, pictures, gestures, or written words to help communicate as needed. Phlebotomists must touch patients in order to do their job, but be aware the patients may prefer being given more personal space whenever possible. Check your body language. Make sure you are not tense or hurried. Watch for nonverbal cues from the patient. Observe their body language, eyes, hands, face. Ask any family members or caregivers accompanying the patient for advice about communicating with the patient as appropriate. Pediatrics is the branch of medicine dealing with people under the age of 18. Children who are old enough to understand that having blood drawn will mean being stuck with a needle may be very fearful of the experience. It's important to be reassuring and take the time necessary with young patients to help manage their anxiety. Young children should be allowed to sit in the parent's or guardian's lap. Some other helpful hints are to 1. As with adult patients, always introduce yourself by name and title. Children can find adults they do not know intimidating, especially in a medical setting. Give the child as much personal space as possible. Lower yourself physically to be on the child's eye level when speaking. Allow the parent or the guardian to hold or soothe the child. The parent may also need to help stabilize the child during the blood draw. Explain to the child, in a way that's appropriate to his or her age, what you will do and the equipment you will use. Speak directly to the child rather than the accompanying parent or guardian. Emphasize that it is normal even for adults to be nervous about a blood draw, but it will not take long to complete the procedure. It can be helpful to give a child a job during the procedure, such as holding or handling something. You may want to provide or allow distractions for the child if possible. Watching a video on the parent's electronic device or looking at pictures in a book might help calm the child. Do not lie to the child about the procedure. Do not say it will not hurt when we all know that's not true. Take any questions a child has seriously. Answer them if they are within your scope of practice. Do not tell the child they will get a reward if he does not cry. If your facility offers rewards to children, do not make brave behavior a condition of the reward. It's normal for the child to be frightened. Geriatrics is the branch of medicine dealing with elderly patients. Older patients may have hearing, vision, or cognitive impairments. They may not have any impairments at all. It's important not to make assumptions about this group of patients. So guidelines for dealing with geriatric patients would include treating older patients with the same respect you give all patients. Never talk down to them or treat them like children. If an adult child or other caregiver is accompanying the patient, it's appropriate to answer any questions he may have, but it's important to communicate directly with the patient themselves. Speaking only to the child or caregiver is disrespectful and suggests that you do not believe the elderly patient is able to understand or communicate for herself. Call elderly patients by their proper names. Do not use terms like sweetie or dearie. Just imagine how you would feel if someone had spoken to your mother or father or grandmother or grandfather in that manner. If the patient indicates that he or she has an impairment of some kind, follow the appropriate guidelines listed above. Developmental disabilities refer to disabilities that are present at birth or emerge during childhood up to the age of usually 22. Intellectual disability is the most common developmental disability. An intellectual disability is neither a disease nor a mental health disorder. People with intellectual disabilities develop at a below average rate. They have below average mental functioning. There are 4 different degrees of this disability: mild, moderate, severe, and profound. Depending on the level of disability, a person may have a legally designated representative for issues such as medical consent. Guidelines for dealing with this population would include introducing yourself by name and title, no secret there. Describe the procedure you'll perform, watching for indications that the patient understands. Treat adult patients as adults, regardless of their intellectual abilities. Give the patient the opportunity to ask questions. Answer questions within the scope of your practice. Remain calm and patient even if there are repeated questions. Watch closely for nonverbal cues that the patient is confused, unsure, or anxious. Slow down and reassure as necessary. When dealing with autism spectrum disorder, is a type of developmental disability that can result in differences in how people relate to others and communicate. Patients with autism spectrum disorder, or ASD, may seem withdrawn, and they may find communication challenging. They may not be comfortable making eye contact or speaking to unfamiliar people. New situations can be overwhelming for patients with ASD, so it's essential to treat them with empathy, patience, and respect. Now, according to the U.S. Census Bureau, over 15% of adults in the United States speak a language other than English in their homes. In some communities, this number is much higher. As noted in Chapter 2, patients have a right to receive information about their medical care in a language they understand. Healthcare settings can be difficult to understand, even frightening, no matter what language a person speaks. This is especially true for patients whose first language is not English. So some guidelines for non-native speakers of English would include: 1. Be familiar with the interpretation services available at your facility and use them when they are needed. It's better off to use a professional interpretation service than a coworker or a family member, because you have legally documented interaction. Watch for signs that patient does not understand what you're saying. Sometimes people are afraid to ask for help when they do not understand. Like I said before, do not rely on the patient's friend or family members to translate medical information. You never know beyond the shadow of a doubt if they're telling you the truth or giving you misinformation. If you live in an area which a particular language is spoken, learning some simple phrases in that language can help put patient at ease. Most patients a phlebotomist works with are likely to be polite and easy to work with. Occasionally, patients might pose more of a challenge. Whether due to illness, anxiety, frustration, or personality, patients may display combative or inappropriate behavior. The way a phlebotomist communicates in these situations can determine whether the situation improves or worsens. Sometimes the best choice is to get help from a supervisor. If the phlebotomist ever feels threatened or unsafe, they should leave the area and contact the supervisor immediately. So some general guidelines to deal with the combative, angry, or inappropriate behavior is to: 1. Stay calm. Do not argue or respond to verbal attacks. Allow the patient time to calm down. Lower your own tone of voice. Be flexible and patient. Trying to find out what's causing the patient's behavior. Using silence may help the patient explain. Listen attentively as the patient speaks. Stay a safe distance if the patient becomes combative. Never put yourself in a situation where the patient is between you and the exit. If the patient makes an inappropriate or sexual comment, address the behavior directly, saying something like, "That makes me uncomfortable." If the patient persists, stop the interaction, call for help immediately. If a patient attempts to physically strike you, do your best to block the blow and get out of the way, but never hit back. If you are a victim of violence by a patient, you have to understand that there is a difference between self-defense and retaliation. So if you hit a patient back, that is considered retaliation, and that can lead you subject to a lawsuit. And always report inappropriate behavior to a supervisor, even if you think it was harmless. And that is the end of this presentation. As always, if you have any questions, please bring them to class, or you can post them up on the discussion board. And have a good week.